to everyone for joining us today. For those of you who are joining us for the first time, iCourts is a community of practice whose goal is to connect people who work in the social and behavioral sciences field of neglected tropical disease. Once a month, iCourts hosts a Knowledge Café webinar where we provide the opportunity for community members to present on a topic of their choice to a global and virtual audience. If you have any ideas for a Knowledge Café, please reach out to us at info.icourts@gmail.com. And if you'd like to join as an iCourts member to stay up to date on our activities and events, click the link in the chat to fill out the Google form. This webinar was developed in collaboration with iDARE. Today, we will be discussing utilizing the iDARE methodology to increase mass drug administration access in South Sudan. We will start off with a 10-minute presentation by Dr. Taroub Faramand and Sarah Papa, followed by a 26-minute presentation from Dr. Abuk Peter, and a 20-minute discussion period. During the session, please feel free to put in any comments or questions you have in the chat, and we will address them in the discussion portion of the session. Please note that this session is being recorded. I will now pass it over to Sarah Jane Renfro, our session moderator.
Thank you so much, Farsa, for that wonderful introduction to iCourts and setting the stage for today's discussion. Hi, everyone. I'm Sarah Jane Renfro. I'm a Senior Program Associate for Gender Equity and Social Inclusion at iDARE, and I'll be moderating today's discussion on community-driven approaches in global health. So let's begin with Dr. Faramand and Sarah Papa. I'm going to share screen. Okay, passing it over to you, Taroub.
Thank you so much, SJ, and thank you everyone for joining us this morning, this afternoon, good day. We really appreciate that you're allocating time to learn, and we want to learn from you as well. So I will briefly discuss or update you on the iDARE methodology and why we came up with this methodology and what it does to transform MDA access, specifically in South Sudan. I will be very, very brief. So next slide, please. So the iDARE methodology we came up with almost 12 years ago. We have been implementing it in a variety of programs, and we have observed incredible success in closing gaps and improving health outcomes. iDARE stands for a process, a 5-step process that basically builds the capacity of local implementing partners and communities in identifying and implementing and monitoring and evaluating solutions that work for that specific community. It is based on the science of improvement, behavior change theory, and design thinking. And it is, as I mentioned, a 5-step approach. So the first step is to identify gaps. We train local implementing partners and communities in identifying gaps, either by looking at the existing data, and many times we train them on how to collect data and what does the data mean for the health outcome that they are trying to accomplish. The next step is for the communities themselves to think about solutions that work for them specifically. And as you know, every community has different problems, have different gaps, have different ways of identifying solutions. And while they are identifying solutions, we train them on the do no harm process. And it is very, very important that we take that into consideration, where they need to think about whether a solution might harm any member of the community. The third step is they apply and assess whether the solution they identified is working or not. And during that process, they will be monitoring continuously the data and the results. And if the solution does not work, they let it go and they identify other types of solutions. Of course, recording, monitoring data is at the core of that process, and expanding is an important step, because during the expansion, we have to monitor and be very mindful of the different changes that might affect programs. So I'm going to stop here and hand it over to Sarah, who will explain, give you more details about the iDARE methodology. Sarah?
Thank you, Taroub, and thank you again to the iCourts team for having us. I think just to stay quickly on this slide, I know Taroub gave a really nice overview and background of the iDARE methodology and the steps, and I think A really key piece about the steps as well is, they definitely are cyclical. It's something that we repeat, we kind of re-emphasize throughout the process. And one of the most important steps is that identify step, because we want to make sure that we are embedding this process for consistently documenting gaps, documenting barriers, understanding what's going on, because we know that as we're implementing programs, as we're engaging with different communities or stakeholders, conditions are always changing, new factors are arising. So it's important that we have that identify step consistently in place, and that there is a system for ongoing adaptation, trying new solutions, learning from what we've done, what's working well, what's not working. So just to kind of emphasize that these steps kind of are ongoing throughout the process. Next slide. So why iDARE? And again, Taroub and I want to just give a bit of an overview of how we've implemented iDARE, how it works, and then again, Abuk will give us a much more detailed look of its implementation in South Sudan. But the reason, when we're applying iDARE, a lot of times we're seeing that there are these persistent gaps in really reaching the hardest to reach populations or last mile communities. Many times, there's much higher level strategies, big programs, especially something like mass drug administration. So it can often be very challenging for a large program to really be able to pay attention to and address those very hyper localized barriers that may be small but have a huge effect in terms of the people that are being reached or are accepting treatment, or kind of what's that bottom line when we're talking about reaching entity elimination goals. So a lot of times, when we're bringing in iDARE, it's to really understand that whole hyper localized context and be able to respond to that, and in turn it makes a much bigger impact. Another point that we're often seeing, and I think we're all experiencing in our programs, is the complex environments that we're working in and the need to really be responding to that in real time. So a lot of times we've been implementing iDARE. It's been in conflict affected areas, post-conflict areas with high mobility or migration of people, the impacts of climate change, or even rapid urbanization. A lot of times those complexities can really amplify inequity. And as we often see, one of the biggest issues that will come up is just trust. So whenever we are supporting programs, giving drugs in communities, trust can be such a big limiting factor to not even just reaching people, but people accepting drugs and feeling okay about taking them year after year in MDA campaigns. And so where iDARE really comes in is it offers that much more community-driven approach in the way that we identify and engage local influencers to use that information that's gathered through that identify step and come up with solutions to really reach those groups. And because it's coming from trusted influencers, we have that built-in trust in the system. So it's something that really works in those really unique and more complex situations. Next slide. So what does it actually look like in practice? Typically, we have a pretty multi-level implementation plan whenever we implement iDARE. Now, it really shines at the community level where we're working in the hardest to reach areas, but we want to make sure that it's an approach that's sustainable and really has local ownership. And a lot of times, and as you'll hear a lot today, really at the root of iDARE is we're addressing gender equity and social inclusion issues. iDARE can be used for many topics across many sectors, but when we're talking about using it to reach the hardest to reach, inevitably that comes along with addressing GESI. So you'll see a lot of that in our presentation today. But typically, we're starting with a much more formative GESI assessment to lay the groundwork to really understand what's going on. We work hand in hand with the national level, helping capacitate national level stakeholders in the Ministry of Health, as well as working on different policies or strategies to ensure that kind of GESI approach and that iDARE learning is embedded throughout. Then looking at kind of the hardest to reach areas, we work to those subnational areas of a given context or country. where we are equipping GESI teams, again, often with local government, different NTD stakeholders, to really champion and steward that iDARE process at the community level, where we are then directly working with cohorts of individuals who have not taken or missed previous MDA or often never treated, to where, we're not just learning from them to understand, the reasons why, what are some of the barriers they're facing, some of their beliefs, but also use them as kind of a way to test solutions, to by then, engaging local behavior change teams with those influencers and working with those cohorts to see, if we do it this way, if we hold this type of information session, if we ensure that MDA is given at a certain time of year, we can better reach these groups of people. But so we're engaging those cohorts throughout the process and really embedding that learning through everything we do. So, and then that kind of gets to the local solutions phase, where again, we are, giving the tools to those local behavior change teams or iDARE teams to design, apply, and then adapt different solutions. And then one of the most important pieces then is they're kind of, just as the identify step is really built in throughout the process, we have ways to document this learning throughout the process as well, because this is the most important piece, is not only showing what works in a given community, but how we can further adapt MDA on a much larger scale. And in certain settings where we've done iDARE for many years and we've expanded it to many communities, we've really been able to do that and be kind of a core MDA strengthening piece, and using that learning to then adapt a much larger scale program. Next slide. And then lastly, before I hand it over to Abuk, I want to just give a quick spotlight of how we've applied iDARE and kind of the experience and the learning that has now gone into this implementation in South Sudan. iDARE has, as Taroub explained, has been around for many years. We've applied it across sectors, primarily in the health sector, with, for example, with maternal health, gender-based violence, HIV, TB, but we've also applied it in local communities to improve conservation and biodiversity efforts. So it's a really versatile methodology. But in terms of the NTD type of work, we've implemented it in 6 countries, South Sudan included. And this just gives a quick snapshot of some of the things that we've been able to do with iDARE. And again, kind of going back to that multi-dimensional model, we've been able to equip, several national and subnational GESI teams, really strengthening their capacity to integrate GESI and then use that iDARE process to encourage behavior change at the local level. And that is in support of over 1,000 community influencers over time who have served on and kind of worked in those behavior change iDARE teams. Oftentimes when iDARE is implemented in a community level, we've seen on average a 17% increase in village level MDA uptake. So that's, in addition to or part of a larger NTD program, but we're really seeing a nice advantage or a nice boost whenever the iDARE work is happening there. And then among those cohort members, so the groups of people that have never been reached or never treated, where we're kind of working with them to learn from them and test solutions, we're often seeing about an average of 99% uptake of MDA. One thing that's been interesting is a lot of times we're using iDARE as an MDA strengthening tool, but again, the solutions are coming directly from the behavior change team. So in settings where we're helping address trachoma, for example, the behavior change teams are often in some ways pivoting and really looking at the facial cleanliness, the hygiene, community hygiene, and household hygiene behaviors, and doing things like promoting latrine use, promoting men's engagement in facial cleanliness at the household level, and even engaging youth in those activities as well. We've done a lot to use iDARE learning to integrate into training curricula for MDA, to different strategies and policies. And then one last piece as well, and I think that it has a nice segue to South Sudan, is whenever we have been implementing, we always, because learning is so core to iDARE, we want to leave room for how can we improve the methodology? How can we make the tools more accessible, more effective? So for example, we've applied iDARE, pretty large scale in Uganda, and we were seeing that at the local level, the paper-based tools were just not going fast enough in terms of feeding information back to MDA teams. So we decided to digitize one of the core components of the tool, which is the root cause analysis tool, something that we use to engage with cohort members and to gather new information and new learning. So we digitized that version. That way it was, information collected in real time, analyzed quickly, and fed immediately back to MDA teams, especially as they were in the midst of drug distribution. So it's, not only did it kind of speed up the process, but also we're engaging other NTD stakeholders at the community level to use these digital tools. So it's also improving local digital literacy. But what's been interesting is we've now been able to expand that in South Sudan, and it's given us another opportunity to adapt that approach. So this just gives a nice overview of iDARE, but with that, I would love to turn it over to Abuk Peter. She is the GESI focal point at the Ministry of Health in South Sudan, and she's really been leading this GESI and iDARE work. So over to you, Abuk.
Thank you, Sarah. Good morning, good evening, good afternoon, everyone. Welcome, and thank you to iCourt for having us today. So today I'll be taking us through how we are utilizing the iDARE methodology in South Sudan, and how we are using it to transform access or uptake of MDA. So South Sudan suffers from 6 preventable neglected tropical diseases that include trachoma, onchocerciasis volvulus, and can you hear me? Hello?
We can hear you, Abuk.
Oh, okay. So, like I said, 6 preventable neglected tropical diseases that include trachoma, onchocerciasis volvulus, and lymphatic filariasis. But despite the ongoing mass drug administrations and effort by the Ministry of Health and its supporting partner, there is still transmission of the diseases. So, in order to combat this, the Ministry of Health, with support from its partners, iDARE, CBM, and CAT Center, and support from Arise Fund, tried to identify what could be other barriers that lead to this continuous transmission. Could be geographical barriers, could be social barriers, gender barriers, or any other barriers. So in order to come about this, they utilized the iDARE methodology that's developed by iDARE to try to identify those issues. So next, please. Yeah, so in 2024, we conducted a GESI assessment in Aweria and Kabota North counties of Lake State and Eastern Equatoria State, respectively. So both counties, in Aweria, they only suffer from onchocerciasis volvulus and lymphatic filariasis, and also SHIS2, but at the moment, we only have intervention for onco and LF, while in Kabota North, they are suffering from trachoma. So in 2024, the Ministry of Health, with support from its partners, we tried to conduct a GESI assessment. We conducted an RCA in Kabota North and a full GESI assessment that is composed of RCA, focus group discussions, and key informant interviews in Aweria County in order to identify what could be the barriers. Are there any gender or social related barriers that affect the uptake of MDA and the success of the program? Because despite ongoing mass and drug administration, there is still low coverage in those counties. So we wanted to know what could be the issue. So we conducted the root cause analysis and the focus group discussions and the key informant interviews to identify those barriers. Next, please. So why we chose those locations, Aweria and Kabota North County. So Aweria is located in Lake State, that is located in the northwest side of the country, and they both share while Kabota North in the eastern part of the country, they both share similar context. For example, the communities there are simple communities that depend on farming and cattle herding as their own source of income or cultural heritage. And they both have gender and social barriers that prevent where it's most believe that women have no autonomy over their over choosing whether to participate in MDA or not, but we wanted to confirm this ourselves. Next, please. So currently, we finished the identify phase of the iDARE methodology, and we are in the design and applying phase. And I want you all to know that iDARE methodology is still new, and we are still going through it as we are presenting to you. We are not presenting something that is ready or like finished, polished. We are still taking you along the way with us. So we already conducted the assessment in Awaria and Kaboita North counties, and we identified those barriers to accessing MDA. And now we are in the design and apply phase, which we already presented the results. We disseminated the results in Awaria County, and we provided a coaching visit, and we are going to provide another coaching visit before the MDAs that are going to take place this month. And we also have a WhatsApp group to keep in contact with the influencers that are on ground. And I'll come to the influencers in a bit. And we are going to do the same dissemination in Kaboita North County. So after identifying all the reasons or the barriers to accessing MDA, we identified influencers. We call them just influencers. And these influencers are people that were identified by the community themselves, people they trust, people they believe in, and people who have a significant importance within the communities, and they hold a significant importance, and they can affect how decisions are made within the community. Some of them are Boma health workers, some of them are Boma chiefs, some of them are traditional healers, some of them are religious leaders. So there were people trusted by the community to guide them. So we identified those people, and then we trained them on the diseases themselves. We trained them on what is onco, what is LF, what is trachoma, how they are being transmitted, what could be the possible cause of the disease themselves, and how you can prevent or treat yourself. So this was important because there were so many, sorry, this is the next slide. It was very important because we found in the places where we went there that there are so many cultural misbeliefs about the transmission of the disease, how you can get the disease. For example, in Awaria County, people believe that if you step on an elephant feces, you might get infected with lymphatic filariasis, and also hydrocele is caused by severe caning on your lower back. In other places, trachoma, in Kaboita North, people believe that trachoma is a witchcraft. So it was very important for us to identify those influences from the community, train them on how the disease is transmitted and how you can prevent or treat yourself, and the importance of taking MDA. So from assessment to action, how are we putting iDARE into practice? How are we transitioning from identifying to designing and applying the solutions? After doing the assessments, we had several meetings with the stakeholders, with the influencers, on how they see best is to engage the community, how we can help them so they could help us to engage the community more. So we have mobile communities, we have IDPs, we have cattle herders, we have pastoralists, people who tend to move a lot, and they were really hard to locate or track, and most of the time they miss MDA. So we found that, yeah, we have mobile population, and it's very hard to track them. So instead of trying to track those people, because we are external, we are coming from outside, they will not listen to us. We try to have people from within those communities to train them and make them influencers to also help influence the rest of the community. You can see here on the slide, we have so many barriers that we have identified. You can read them yourself. And then what are we doing now? Also from the community, we ask them, so now we know the barriers, how are we going to help you? What do you need us to do? So one, to train the community influencers from within those communities to help become a behavior change agents, and also to allocate the cohorts. So they offered to help us to track those who missed the previous MDA and talk to them, people who were with them in the same village. So after now they know what the diseases are and how they can prevent them, and they know like all those misconceptions are not true about the diseases. So they offered to now go and talk to those cohorts. We identified them. We assigned those cohorts to them, and now the influencers in Aware County at the moment, they are tracking those cohorts. They're talking to them and how to see their intention to take MDA. Are they willing to take MDA or not? If there are still people who are refusing to take MDA, they're going to talk them to try to influence them to participate in MDA. Next, please. So, community influencers network in action. How are we building the local capacity for the sustainable change? Like I said earlier, we train the community influencers. And we have coaching visits that we do. We already did one, and we're doing the next before the MDA. And then we have a WhatsApp group where we keep in touch with the community influencers. We talk to them, we see how far they're going with engaging the IDPs, the cattle keepers, the other community members that were refusing to take MDA the last time. So the number of cohorts who did not take MDA in the previous MDA in 2024, there were 36 cohorts, 6 males and 30 females. And we allocated them to 12 trained influencers, and they were the influencers were selected based on the village location, and we assigned the cohorts who were with them in the same villages. We don't want to, again, because the influencers are not fully employed by us, we don't want to give them hard time. We want them to do this in their free time when they have time. So we had to select people who are with them in the same village so they can meet with them when they're going to the market, when they're going to school, when they're going to work, or when they're just having community gatherings, and to try to talk to them, to influence them, and engage also the rest of the communities. And this is going to be also through school meetings, community gatherings, weddings, religious events in the community, and also focus on the mobile populations. So in Kaboita North, there were 72 cohorts, 31 males and 41 females across 4 payams. And Kaboita North at the moment is going through pre-task, and that's evaluation to see if they still need to go through another round of MDA or not. So Kaboita North is not going to have another MDA, but still we are still engaging with the influencers in Kaboita North to strongly advocate for wash interventions and how it's important to have a clean or a good hygiene habit to prevent trachoma. And also we want influencers to actively engage the community with good hygiene practices, and also try to link the community members with the what's the word? Sorry, to try to engage the community with I would say implementing partners that are doing wash or hygiene practices programs in the community, or like where they can find clean drinking water, because in the context of both counties, Awarial and Kaboita North, there is difficulty in finding clean drinking water. So they are implementing partners on ground that help those communities with clean drinking water. So this is one of the things that the influencers are also trying to help to do, and to integrate the wash interventions or good hygiene practices with the schools and religious institutions. Next. So how are we addressing the diverse community needs? So as you can see, I'm not going to go through all of them, but I'll just highlight some few of the solutions. For the mobile populations, we are trying to map the seasonal migration this is going to be done by the influencers themselves, because the influencers have a local network. They know people who are cattle keepers, or they know people who know cattle keepers. So it's best for the influencers to track them to see when these people are migrating and which paths they are taking, to help influence them or train people. And we are training people from the community, from the cattle camp community or the IDPs community. We train them as supervisors or community drug distributors or social mobilizers, to train them and include them in MDA, and so they can go back and influence us. Because this community, sometimes they don't want people from outside to come to them. So instead of us trying to take this, we are trying to make this a community-owned or community-led intervention. So this is one of the things that we are doing. We also involve them in the planning. For example, we try to know when to schedule MDAs, because South Sudan, to be honest, is affected by climate change. We have seasons of floods and droughts in most of those areas. So the best way to have a successful MDA, we need to involve the locals, because they know when they will migrate from this place to another, or when there is flooding or when there is drought, how to overcome those barriers. And for the hard to reach populations, people in the islands, there are people living on islands in Awariel County, because Awariel is along the river, and those people during rainy seasons, they tend to migrate because they are affected by flooding. So it's very hard for us to locate those people and to find them. So what we do is we try to have either house-to-house mobilization for populations that are living with disabilities, and temporary MDA sites for people who miss MDAs due to other reasons. And for wash-related preventions, we try to have community dialogues on hygiene and prevention. We try to incorporate that in schools, religious institutions, or any other community gatherings, in order to help to prevent some of the waterborne diseases, for example, trachoma. Next. So, as we are doing this in a real time, and we are monitoring this. Like I said, we have coaching visits, and we have WhatsApp group where we track the progress of what we are doing at the moment. So the current baseline in Awariel, from the 36 cohort that were interviewed last time, 88.8% are intending to take MDA this round, and the MDA is going to be this month in June. And our target is to increase the coverage to 100% in those communities, or the people who missed MDA, instead of 88.8%. We want the 36 cohorts to take MDA, not only 32. In the monitoring approach, we have regular follow-up with the cohorts members who missed. That's done by the influencers, and we are documenting their reasons for resistance, why they still intend now to take MDA this round, and we are tracking their behavior change. Are they still willing to be flexible, or they're still rigid or resistant to the change? And we are adapting management based on real-time feedback. Next. So, working within the culture or social existing structures, when we were doing those assessments, we faced some resistance from the community members, because like I said, we were new to those people, and then the information we were trying to pass to them was new to them. It's not the same as they have in their communities. So we had to go and talk to the local leaders, the community leaders, the traditional healers. We want this to be culturally sensitive. We are not trying to remove or erase their culture or their beliefs, but we want to look at the positive side of those cultural beliefs. So involving the traditional healers and the local leaders into the mobilization or sensitization progress was really important. So, like I said earlier, there were so many conceptions on ground on how these diseases are transmitted, on why or why you can get the disease itself. So by involving the local leaders and the traditional healers, we were able to pass down our message without finding much resistance. And this also would enable community leadership. Instead of us taking the lead in everything, we gave them the chance to feel like they are being recognized and they are being respected in their own communities. And this led to trust between the local leaders and the community and us in whatever we were doing. Also, we tried to involve youth, women, and other religious institutes in this program to also help, because in those communities, most of the time women are not allowed to come into those community gatherings. So in order to reach those women, we had to involve the women leaders, the chairperson of the women institution in those areas. We involved them, we talked to them, we explained to them, and also to make the women in the community feel free to talk, to express what they're doing. And one of the solutions also that was suggested by the influencers, a woman, she suggested that because we know that if you get lymphatic fluorescence, you can get hydrocele. Sorry, men get hydrocele, and sometimes women have breast enlargement due to the disease. So they suggested that we could print out all those complications from the disease, and they can go back to the community and show the women, because they say most of the women in their communities are not educated. So when they go and talk to them and say that all the medical terminologies, they're not going to understand. So they need us to print out to other people, to print out the side effects or the complications of the disease, and they show it to the women in the community. If you don't participate in MDA, or like you're not going to prevent yourself from this, so you need to participate in MDA to prevent yourself from this. Next, please. So early lessons, what we learned as we were we were conducting go through this, instead of us going to act like we own this. We wanted the community to own this. And we have noticed when we tried to do the lead, the community was resisting our help. So when we involved the community leaders, the local healers, there was acceptance from the community. I'm not going to go through all the challenges, but the lessons, sorry, but you can read them. Now, the current challenges is resources constraints for the transportations and logistics, and also balancing traditional beliefs with medical evidence. Yeah, as the local healers and the local leaders are trying to debunk all the misconceptions and the myth about the disease, but it's still a resistance from the community, and it's something we are still challenge we're still facing, but we are trying to adapt on or see other solutions. And the adaptations that we make, we are planning to add the cattle camp years that was suggested by the community, and to expand door-to-door strategies for the populations with disability. Next, please. So what are our next steps? Now we are in the design and apply phase. We are trying to apply the solutions that we learned and the community gave, also the recommendations committee gave us, into our solutions. So we are going to complete the 2025 MDA cycle with enhanced coverage tracking. We are going to try to apply all the solutions we learned on how to access the population or the communities better in order to enhance the uptake of MDA. And to sustainability and scale-up potentials, we are going to enforce local capacity building to ensure the community ownership, and to continue using evidence-based policy and program improvement. Next, please. Thank you. This is a picture from the influencers training in Kaboita North. And yeah, iDARE is the transition from JC assessment to community-led implementations to demonstrate how iDARE methodology transforms research findings into tangible behavior change. Thank you.
Thank you so much, Dr. Abuk. Let me just get my camera on. There we go. Thank you, Abuk, for that really insightful presentation. This was a really powerful example of how the iDARE methodology is being translated from the assessment to real action on the ground in South Sudan. The community-driven approach you've described, from working with cattle herders to, as you were just saying, engaging traditional healers, really demonstrates the importance of culturally responsive solutions. So now we're moving into our discussion period. And we'd love to hear from our presenters as well as all of you in the audience. Please feel free to use the chat or raise your hand. Just to kick us off, Dr. Abuk, one quick question. You are implementing, as you said, 20 targeted solutions in Awarial and 12 in Capoeira North, each tailored to the specific barriers that you identified in those communities. I know that you're looking into scaling this approach to other counties in South Sudan. So what do you think will be the most critical elements to adapt versus the core components that should remain consistent across the different contexts? Abuk, if I could pass it back to you for that question.
Okay, thank you, SJ. So I think the one most important element is to always involve the community in whatever we are doing. Beginning from the planning to how we are going to implement what we are doing. What was the second question? Sorry.
Yeah, so it was basically, what will you what are the core components that should remain consistent as you adapt to other contexts? But also, what do you think is important to change? What are you going to be taking into account as you scale this approach to other counties in South Sudan?
Okay. I will just take into consideration being flexible and always knowing that things are not going to work the way we want them to work. I would say the identifying element. We might have some barriers that we have in mind before going on ground, but when you reach there, there's so many different elements that are going to shock you, different barriers. So we always have to be able, we have to be ready to be flexible to know that there's going to be change.
Amazing. Thank you so much, Dr. Abuk. And then it looks like we've got a question in the chat. It's an amazing concept. Thanks for sharing. Would like to learn who facilitates the discussion at the village level, project team, or the health workers. Dr. Abuk, could you talk a little bit more about how that happens practically? I think you're muted. So
Sorry, I'm muted. So how we do this, we try as much as possible to have discussions. The discussions is basically, most of the time is made by me or other colleagues, but we try to give the community an overview of what JC is on the iDARE methodology, but from there the community take charge, the community influencers or the NTD focal point or the CHD. These are the people who are working in the county, at the county level. So only the first step is taken by us. We give them an overview of JC, an iDARE, but the rest of the process is done by the community, by the county health departments themselves and the influencers.
Amazing. Thank you, Dr. Abuk. So a little bit more about interactions with traditional healers. Someone asked, were they willing to encourage community members to participate in MDA? Could you talk a little bit more about that engagement with traditional healers, especially with deeply held cultural approaches to MDA and NTDs?
Yeah, the community the local healers are willing to influence the community members to participate in MDA, as long as we do not try to erase them completely. They're okay with us acknowledging that they are an important part in the community, and we are going to work hand in hand with them rather than just us taking the whole spotlight from them. They're not going to accept that. But most of the community local healers are willing to talk to the community members to take MDA because they have a lot of misconceptions that most of these diseases are witchcraft. And the second question, how to hear more about introductions and willing to encourage. Yeah, I think I've answered that.
Yeah, amazing. Thank you, Dr. Abuk.
Thank you.
I'm gonna send this next question over to Sarah Papa. Sarah, could you talk a little bit more about, there's a question, are you asking people if they're ever treated with MDA? For example, if they're never treatment.
Sure. Yeah, thank you for this question. So typically, whenever we implement iDARE across the different countries and contexts that I had mentioned, a key first step is looking at past MDA coverage data. And that also, helps us understand where we need to focus the activity. So kind of what villages or what communities in particular based on levels of coverage. Then we look at the individual MDA data, we identify those cohort members that we mentioned, and then we reach out to them. And a lot of times, we're looking at who has not taken MDA in the previous round. But if the data is robust enough and we can see, several rounds back, and if they are never treated, then that's kind of our first priority. And then when we conduct the root cause analysis with the cohort members, we do directly ask that question. So we try to prioritize those never treated populations. And a lot of times, as we've implemented iDARE across countries, that's typically who the cohort is that we're working with, are never treated.
Thanks, Sarah. And I know that there's a question in the chat that Dr. Abuk has answered a little bit in the South Sudan context, but could you talk a little bit more about other contexts that WIHER has worked in terms of engaging with traditional healers and local beliefs about disease causation and how we've navigated that cultural integration piece? Sarah, this one would be for you if you're available.
Oh, sorry.
Sorry,
so
just for other, sorry. So this is just because I know that Dr. Abuk has talked a little bit about this in the South Sudan context already. There's a question in the chat, but maybe if you could talk a little bit more about other contexts WIHER has worked in terms of navigating the cultural integration piece, particularly related to traditional healers and local beliefs about disease causation.
Sure. Yeah. So, I think, again, our approach is very similar to what Abuk mentioned in terms of, I think the key or the core of it is really working with the local influencers and local teams, because they're the ones that are going to help us navigate that kind of cultural integration, some of those sensitivities, and really understand how to respond and work within those settings. So I think, across the board, we definitely have encountered that in many settings. I know in terms of like traditional healers, kind of local beliefs around the disease, a lot of things that Abuk was mentioning in South Sudan, we've seen the same types of situations in Uganda, for example, and we've had to navigate that. And I think that is also where you get to those very kind of hyper localized contexts where you have to look really small, because these things, you're not going to see them on a much broader scale when you're implementing a large NTD program or MDA program. So that's where we really rely on the methodology and the tools to tell us these things. But I think it goes back to just kind of relying on solid methodology and a solid approach to give us what we need. And again, that's having that process for engaging local influencers and helping that, they really drive the process. And I think one thing that I'm not sure if we've mentioned, but when we are engaging with the cohort members who are often never treated or have not been treated previously, and we're learning from them and conducting kind of a root cause analysis with them, one thing we are asking them is, who is really shaping your decisions? Where do you get your information from? Who influences your health-seeking behavior or even accepting MDA? And that's how we begin to kind of put together almost like a list of the influencers, because we don't necessarily want to go in and just say, okay, we anticipate, these local leaders are going to be the ones that we're going to work with. Like, Of course, that is very important, but at the end of the day, we want to hear from the cohort members themselves, because it might just be, someone in their families, or a teacher, or someone we might not think of because we don't live there. That's not our community. So that's where we really rely on working with those most affected. So I think it's we're seeing these distinct elements in a lot of places, but again, it's really relying on the methodology and the approach to help us get there and do it in the right way.
Thank you, Sarah. That's super helpful. Another question in the chat that I'm going to pass over to you, Dr. Abuk. And I know that the answer is yes, but if you could talk a little bit about how you have been working on integrating gender equity and social inclusion into the national NTD program frameworks like MDA guidelines, standard operating procedures, the NTD strategic plan, etc. So Dr. Abuk?
Okay, thank you. So yeah, we tried, but when we started the Jesse work, we started in, I would say mid or late 2024, when we have already published our NTD master plan, but we have a midterm review and we are going to incorporate, we have a Jesse action plan or master plan that we are going to integrate into our NTD master plan.
Awesome. And then maybe, Dr. Abuk, if you could talk just a little bit more about your work doing training of the trainers, engaging with other stakeholders to train on Jesse throughout the Ministry of Health and throughout stakeholder engagement in your work.
Yeah. So every year we have, before we start MDA, we have a master training of trainers or master trainers. So we invite people from the states. We have 10 states and 3 administrative areas. We invite their state coordinators. We train them on, we refresh them on the diseases themselves, onco-LF and trachoma. But this year and last year, we added the Jesse element into the training. We trained them on the overview of Jesse, what is gender, the terminologies of Jesse, what we mean by gender and what we mean by sex and how this is different and why we're choosing equity over equality. We give them all the necessary information that they need to know, so they when they go into the lower levels, they integrate this into their trainings. And with the other stakeholders, we always try to involve all the relevant stakeholders. And for Jesse, it's not only in the health sector, but we also try to involve other sectors, like the environmental sector, gender, the Ministry of Gender, Gender and Social Welfare. Yeah. So we work with so many stakeholders, not only in this health sector, but in other sectors as well.
Thank you, Dr. Abuk. That's super helpful.
Thank you.
So now I'm going to direct the next question toward you, Sarah. A little bit about sustainability. Can we talk about how do you measure whether behavior change is actually sustainable after the intervention ends?
Sure, it's a really good question. So I think I want to talk about the behavior change side, but also the approach itself and how we're ensuring that it's sustainable, because then I think that will really speak to that changed behavior. On the behavior change side itself, so actual health behaviors or hygiene behaviors, I think the model of bringing in the local influencer teams, if it is a behavior step, they in many ways, because kind of gender equity, social inclusion is at the root of this. A lot of times, we're pairing the iDARE implementation with sensitization of community members, of the behavior change teams themselves, of those district Jesse teams or subnational Jesse teams. So that is really key. So we're really kind of building that understanding of why certain behaviors are important. Or for example, when I had talked about some of the WASH behaviors that the behavior change teams were promoting, some of that was just through them showing that behavior. So almost being kind of like positive role models in the community. That also went along with promoting male engagement in like facial cleanliness, like washing their children's faces in the home, which often was the responsibility of the woman. So it's really just, again, because they are a trusted source and people know them, they're from the community and they are modeling these behaviors, through their kind of work with the iDARE approach. That makes it sustainable in that sense. But I think in terms of kind of promoting this behavior change approach, the reason why we start at the national level and then also at this subnational level is we want to build the capacity of NTD stakeholders, of local government, to integrate iDARE into their kind of health planning approaches. And we've seen a lot of success, you know, in countries where we've worked over time at doing this. For example, in Tanzania, we built the capacity of kind of the national NTD program, and they had been working with us, helping implement iDARE along the way, and then they've adapted it and kind of used some of those elements for other health areas, like immunization campaigns where they were seeing a lot of resistance in a certain community. The same thing has happened in Haiti. The MOH utilized a lot of the elements for a COVID vaccination campaign where they were seeing a lot of resistance in the community. In Uganda, we've been able to, not through NTD programming, but another health program where we've used iDARE. It's now been integrated into like the Ministry of Health kind of behavior change official guidelines. So we also tried to embed this process in, you know, policies, kind of practices at numerous levels, so that there is that local ownership to be promoting this behavior change. So you're kind of getting it from both sides.
Amazing. Thank you, Sarah. And I know we only have a couple of minutes left, so I'm going to stop the question and answer session here. I will say I've put our contact information in the chat. Please do feel free to reach out with any questions or follow up to the 2 email addresses that I've put in the chat, and we can connect you with anyone else from the team that would be relevant to support your questions. Otherwise, I'll pass it to Varsa, but before I do, a huge thank you again to the iCourts team, and thank you to you all for participating. It's really been a privilege to share more about our work and about WIHER's methodology with you all. So I'll pass it over to Varsa.
Thank you so much to Dr. Abuk Peter, Dr. Taroub Faramand, and Sarah Papa for presenting at our Knowledge Café today. Most importantly, thank you to our session moderator, Sarah Jane Renfro, for moderating this discussion session. If you would like to know more about WIHER, and if you have any follow-up questions to the WIHER team, please feel free to reach out to Sarah Papa or Sarah Jane Renfro through their emails that was put in the chat. We will be having our next Knowledge Cafe next month. So if you'd like to attend more Knowledge Cafes like these, please sign up as a member using the link in the chat. And thank you all for attending. Please take a moment to fill out the Zoom poll before you leave.